Miko cannot come here, but Miko is her background is in medical education, so I'm very lucky to have this mixture of background in my department. So, first, just where I come from. I'm from Indonesia, from the island of Java, there, and this Purwokerto is in the central Java. It's about 5 hours from Jakarta, our capital city, and 5 hours by train, meaning that 8 hours by car, and 3 hours from Yogyakarta. That's where we are going to fly this afternoon at 11:30. So I think I have to hurry up. Our university is called Jenderal Sudirman. It's named after a former general, the highest commander, military commander at that time. And he died at a very young age, at 34, from tuberculosis that time, while fighting the Dutch. So he was carried with a, during his fight with the Dutch colonial. I once presented this and felt awkward because it was in Amsterdam. So I was talking about the Dutch, and I'm like, okay, this is a bit awkward, but it's okay. There's no hard feelings for today. And so we have 12 faculties, and the Faculty of Medicine is quite young. So we are a new medical faculty, at a public university. We were established in 2001 at the School of Medicine under Biology and the Faculty of Biology. But then we were under the Faculty of Medical Medicine and Health Sciences in 2007, and now we are in our own Faculty of Medicine. So I will talk about just briefly about the development of bioethics in Indonesia, and then what problems we have and challenges for us there, and then a bit of our experience teaching bioethics in our university. So Indonesia, in the year 2000, we established a network. It's the Indonesian Network for Bioethics and Medical Humanities, where I think Dr. Teguh was there at that time. We were working at the same place. No, I wasn't there yet. He was there. But this network is now a sort of some kind of association or network where professors who are teaching bioethics, or at least interested, would go there and discuss about what they are doing. And the next coming meeting will be just next week, and Woro will be there. Unfortunately, I will not be there, but then we will know the current situation in Indonesia, how everything is going. But the meeting is around every 2 or 3 years. And in 2006, we have the standard competence for Indonesian physicians, the Indonesian standard of competence for physicians, and it was revised in 2012. And there, it has stated that one of the competence that physicians should have is the ethical competence. So, but it's like a general, idea of how we should be as a physician. So that's more an ethical attitude, social, but it doesn't have a more detailed description of how or what should we know and how we should do it. And then in 2007 we have this national examination for medical students. So this is a real-time examination, computer-based examination throughout the whole country. So it's something we really appreciate as a standardization for Indonesian physicians. It's quite a lot of work from Gajah Mada. I think they were the pioneer for this. And then followed by the OSCE, national OSCE is also a real-time live examination conducted in many universities in Indonesia, in medical faculties, for medical students. The CBT examination is MCQ, so we love MCQs. It's the most easiest way to assess students and get the most objective, they say objective, answer, and then scores directly. You don't have to do anything else. But what is I think I appreciate is that we are trying to develop the most suitable, the best questions, like scenarios. We have a item review. How often is it, Woro? Like 3 times a year for all the questions that will be tested. So we have, it's called the regional item review meeting. So there, people, professors from all universities gather at each region. We have 3 regions in Indonesia to review the questions that will be tested. But they remain secret until they are published. I mean, though no one knows what's going to come out. So in that way, it's quite good, but still it's MCQ. Bioethics is one field that is tested. So Dirman, our team was very. We are not. We don't agree about that. We have expressed our concerns to the Association of IP is Medical Teachers Association. We say that bioethics should not be there because out of all 83 medical faculties in Indonesia, only maybe less than half of them have taught bioethics, have bioethics in their teachings in their undergraduate. So it's not fair for students. And also, it doesn't make sense if we have to test an MCQ for bioethics. And when we discuss it with students, we often deal with an ethical dilemma of telling the students what the best answer is, according to us, because we often end up thinking this A is also right, B is also right, and we don't even know the right answer. So it's quite confusing for students and for us also. But it's still going on until now. Then we have the legislation for regulation for medical education, which states that all medical schools are obliged to have some kind of unit or department of bioethics in their medical faculty. So this is also not yet implemented, or not all medical faculties have this yet. So that's a brief situation of how it is in Indonesia for now, until now. And in our university, so starting with our university, with the undergraduate teaching. So we have now, for the new curriculum, we have 2 blocks of bioethics. The first one is bioethics and humanities, where we introduce ethics, the basic concepts, we try at least, the basic concepts of ethics. So we use the UNESCO core curriculum of bioethics. People say it's boring. It has only introduced values and everything. But we think students should have. I agree with Professor Maser that students should realize and understand that there are many values there, and it depends on how we deliver it. So we have lectures. We say instructive lectures because we have a big class lecture, but we also have discussions in between the lecture, so inside the lecture. So I would run around the class asking, ask questions and having them debate their answers with each other, and it's quite fun. And then you have group discussions with case scenarios, and then we have community service for this block, where students stay in some what do you call it? Lembaga. Institution where it's all mixed up with institution where with vulnerable people, such as orphanage, panti asuhan, we call it orphanage, or rehabilitation institutions, and geriatric geriatric institution. So
house for the elders.
House for the elders. So they stay there for they don't sleep there, but they go there in the morning, early morning, and then they come home in the late afternoon. And they are not as medical students there. So we say to the institution, they are to work whatever you want them to do. So they accompany the orphans, the elderly, and everything. And the task is they should write something, a story from what they have experienced there. So, and then they also have this task of reflective writing. So after they come home, they should write a diary where they have their own tutors in their group to give them feedback. It's not working that beautifully, but because not all tutors are interested in reading diaries. So, but we're trying to promote that. And then at the end, they should write they have an art project, which is a diary or poem or short story, whatever they want to do with their experience there. And we, as a reward, we upload that in our bioethics gallery. I will show that picture later. But that's you can also go to that link. And then the second block is in the third year, where it's called biomedical ethics. So this is in this block, students have knowledge of, they gain more knowledge on the bioethical issues in each of the field in medicine, such as abortion, in psychiatry. So it's more of a knowledge thing. So we invite many lecturers from the hospital. This is the challenging part, because not all clinicians are interested in doing that. So, but we have been doing it for years. So we have found the right clinician to do that. So we also sometimes join their lecture, and it's not a common thing to do in Indonesia. People might feel like we're like how do you say, it's doing inspection, like, are they doing it right? But at the end, they know that we're not doing that, and we are invited to the discussion. So it's like we ask them to tell their experience in practice, and students love that. And then we also point out one ethical issue or ethical problem in that field, and then discuss it in class. So it's kind of nice for students to know that there is a clinician who is interested in that and in doing that. So yeah, biomedical ethics. So in this block we have many lecturers from the hospital to help us, and we stick with the lecturers for discussions, but we also give them an assignment, which is an art project. They should make a short film of 10 minutes of anything of the topic they have learned, and to make their own movie and have one ethical issue in that film. So that's also their assignment, and also adding to their score. So we don't want to rely on the MCQs only. And then we have the third block, which has something to do with bioethics a bit. It's the forensics and health law. It's actually from the Department of Forensics and Health Law, but we have 1 day of orientation for students because they are entering the clinical phase. So we have some kind of briefing orientation of what they will face in the hospital. Remind them what the goals are and what problems they may encounter there. And we have some role play of the dynamics of students in the clinic, what problems they have. And here we also say to students that we have a consultation service for students if they have any ethical problems there and don't know where to go. And it's starting to work now. There used to be no one coming, but students now come up to us, just pop up and say, we'd love to tell you about something. So I hope it's quite helpful. This is our gallery. You can see there Professor Bidi also wrote something. So there we have short stories, poems, pictures, films. We haven't uploaded the films yet, but we will do that. And it's actually open for anyone, but it's not yet well published, I think. And for the discussion we have in the undergraduate, we use the 7-step method. This is from, we created this. So we used to use some other methods for discussion, like very early in the beginning we used the 7-jump method in PBL, but it really didn't work for ethical discussion because it was more for clinical discussion, clinical cases. So we used the in the Netherlands they use the Nijmegen method. So it's like a few steps for ethical deliberation. But then we thought the tutors here are not familiar with bioethics, so they have problem in identifying what is an ethical problem. So we thought we need a tool for tutors or facilitators who are not familiar with bioethics. So we came up with this method, which is not only for students but also for the tutors. So first there are clarification of terms and context. For students in the undergraduate, they might not know some terms yet, medical terms or even some other terms. And then we ask them, what problems do you see in this case? It can be any problem they perceive as a problem. It might not be an ethical problem, but it's a problem. So anyone can say whatever they think is a problem. And the third step is, then we ask, do you think it's an ethical problem? And for that matter, we ask to help them, what values are at stake? Is it really an ethical problem? Is it really between conflicting values of, say, justice, beneficence or something? Or is it a medical problem? So this is the really tricky part for the tutors and also students, because they have to identify the ethical problem in that scenario. And the fourth step is perspective. So we want them to look at that problem from different perspectives. This also helps them to actually re-identify or identify other problems which were maybe not seen in the previous steps, and also practice looking from different perspectives. For instance, from the nurse perspective in that case, or the family of the patient, or someone else involved in that case. And then the fifth, we then ask the legal aspects, because previously students love to just go to the legislation or code of ethics and say we have to do this and that. But yet when we ask them why, they don't know, because it says like that here. But it's not for all cases you can use that regulation. And an ethical problem is usually it's an ethical problem because we cannot find the answer, the right best answer from the rules that are there. So after the fifth step, then we ask what solution do you think would be best for this case? So then they start to analyze all the different so we have put one ethical problem there. So they must come up with the one ethical problem that we put there. So here they all try to look for the best solution for that ethical problem. So they have to reason why, if they have this solution, why do you think it's that solution? And they might come up with more than one solution. That is more often the case, that they come up with ABC. But the important thing is the arguments behind that. And they make good arguments. They sometimes come up with something you didn't even think about. And it was still with good arguments. So it's something, I think something good, and students are free to open up their mind and express their opinion. So we follow their discussion because we ask them to write some kind of report of what was going on. Just simply type it and then send it to our email. And we don't score it, but we say it's for our evaluation of how's everything going in your discussions. Then we can also look at how tutors were functioning, if this was going right or wrong. But it's getting better and better. It wasn't that good at the start. And this is our third version after 2 evaluations of this method. So it's getting quite better. At the end, after the discussion, we asked them what lessons have they learned from this case. It's kind of like this debriefing phase where they think about what new things they have learned. and also from how they discuss things. So this is the method we use for ethics discussion, and this is for problem solving. So like we know about mercy yesterday. Mercy is how to apply ethical principles during practice in the real case practice with patients. But this is once you have a case, once you treat a patient and then you find an ethical problem and you want to know what to do, then we are supposed to do the ethical deliberation steps. And there are so many methods you can use, and this is just one that we use in teaching. So then after the preclinical phase, students go to the hospital and have their clinical training, which we call clerkship or co-assistant. And there we have not yet have a structured or routine regular teaching, but we are starting very slowly to do that. It's not easy because our hospital has been established for decades, for I think 30 or 40 years, our hospital. But the Faculty of Medicine is just 10 years old. So imagine us going to them and asking for time for ethics is not easy. So we do it very slowly, and we start with the Department of Forensics and Medical Legal, which is the department we have been working with. And we have 2 days or 2 sessions of ethics where we meet the students and we give them assignments to look for one ethics in a small group, one case which they think is an ethical case, and they present it in class of 20 students, I think around 20 students, and they present the case and they go through these steps of analyzing, and then we discuss it together. And we come up with so many interesting cases from students where they have encountered this case during their duty in which department and how they dealt with this. So that we are doing now in the clinical phase. We have also been invited to a few number of departments like pediatrics and OBGYN, where they say, come to our place and we have this interesting case. So we went there and we followed the morning report, and there were so many things that students sometimes forget, or even the clinicians ask simple questions. They forgot to ask simple questions like what the parents do, how much do they earn. They have to do this operation and they are not even sure if they can pay, and what they would do if they cannot pay, and everything. So it's quite interesting, but we don't always have the time to go there. That's a problem, and they also don't are very busy. So this is very rarely happening now. For individual consultation, we started this around last year. So we have some kind of hotline number where we give the students three people our numbers. You can call us or text or something, or email us if you have a problem which you face in your clinical training phase, and you can meet us anywhere. And we don't have a counseling room, but Woro here is a psychologist and she's in charge of the consultation counseling for students. So we sometimes do that anywhere, but also in a certain room, because it's mainly more often when students come up to us, it's something a bit serious and confidential. So so the goals for teaching in clinical training is similar like the undergraduate, but we really focus on ethical discourse, how they share different values and perspectives, and presenting cases is not that easy, because they might tell a case with their with all these emotions, and we ask them, are you really doing this objectively? What have you seen actually? They might say, the doctor is doing this and he's very bad. What do you mean by bad? It's like qualitative an observation. Tell us what you mean by bad. So they have to present it objectively, what they see, so we can all listen and try to figure out what is really going on and what they should do. But also, we also want to improve the learning environment. So there we find so many problems in the clinical training phase. So, and it's difficult for us to do something for now, and we try to help improve the system, but it's not easy. But it's very useful for that. And like as Professor Han said yesterday, I put it there. So some problems they have are very difficult. It involves the whole system. But we say if you can stand up for your own values, and like the first professor, Professor Morgan, by this group shifting, you should be able to do something, improve the atmosphere, the environment you are in now. Although it's not easy. I'll share with you a number of cases. Okay, so these are a few cases we have from students. From the group discussion, we have many cases of teamwork among the students. So they fight with each other about night shifts, about students complaining about their own peers not coming on the right time, disappearing. So they have all these duties that they can finish at one time, and they kind of falsify the follow-up for patients because they have really no time to follow up all patients. And settling peers is, I asked them, so why can't you just tell the truth that instead of falsifying things that you can't do it because someone is missing? I said, no, telling peers. I said, oh, it's not. Is it in the bottom of your dictionary? No, it's not there. You cannot tell a peer. You cannot tell that someone is not there. You cannot tell someone that something bad about your own peers, which is a big problem. And so it's kind of difficult to handle this, but it's there. The phenomena is there, and students have real difficulties handling their own friends and peers who are in their group. And communication, this is the second highest number of cases where communication among students, but most of all with students and nurses and their senior consultants, they find it sometimes very difficult just to communicate something. The case of ER, I thought that earlier, is a case where students brought to us about that they were witnessing a resident. What do you call resident here? Physician in training. What do you call it for a specialist? Is it resident?
Medical officers. Registrar. Medical officers. Medical officers.
Medical officer. So physicians who are in training for a specialist.
Oh.
Registrar.
Registrar.
Registrar. Okay, registrar. So we have a few registrars in our hospital coming from Gajah Mada, from other universities. And he told the family of the patient that the patient had obstructive ileus, and which was quite bad. And he actually told the patient in front of the students that I think he's doing okay, and we'll do the surgery later. Whereas the students really saw that it was really bad, and then the registrar told the students, not with the patients. He told the students that, well, I can't do anything else, and he's going to die. So he saw something different, and they were really disturbed about this. They said, this registrar is not right. He's doing something wrong, and so but they couldn't say anything. They didn't dare to say anything to the registrar. So they brought up that case. And the case of surgery long line is where students witnessed senior consultant scolding a registrar in front of them and in front of the patient, because there was a long line of patients who had to do surgery, who had to undergo surgery, and the registrar somehow made a mistake and ended up patients being in a long line in front of the surgery room, and it was disturbing everything. And the senior consultant was very angry. He just scolded in front of everyone, and the students felt this is very awkward, and it's something really, really wrong, very wrong. Yeah. And case of pediatrics, this case is very sad, and it's coming, I think, in every group, in every round, because students are not supposed to tell death report that a patient is dead to a senior consultant, and the nurses say this. So they say you should never ever call a consultant and say the patient is gone. So and students do not dare to do otherwise, because the nurses are there with them every time. So what they do is they tell that the patient is in critical condition, and for that, of course, comes the order resuscitation. So students, they wanted to cry doing resuscitation, injecting medicines to someone who is already gone. And I asked them, have you ever told this to anyone? No. Why not? Because they don't dare to. So this is something very, really, very wrong. And I don't think that we said to them, we don't think the senior consultants know about this. If they know about this, they would really. We know the pediatrics very well in our hospital. They should know, and we are now burdened with having to tell this, because it has to stop somewhere. So this is a serious case we have to deal with, and the competency or responsibility of co-assistants or clerkship students performing something feel they are not competent yet. This is Woro drainage for surgery, where a student told us that he had to do that during his first year, and he has never performed that before. And because the registrar was too busy, he has so many patients. I said, please do this. You know how it goes. You have the skill. You have done it in laboratory skill with a mannequin. So if you need anything, just call me there. So he just ran to another patient. So luckily the patient he did it very well. And the patient was good, but he said otherwise. But if not, the patient would have died, and I don't know who would be responsible of that. So those were the cases for group discussion. Students brought this to the group discussion. We also have more strange cases in individual consultation. So these are mainly unethical behavior of senior staffs. They have this doctor who they call Dr. HP. HP is HP, is for handphone. There's one doctors who love using handphone. So he walks everywhere like this, and even in front of the patient. So there he's examining, and then he just suddenly uses his handphone. And they consider this very rude to patients, but they don't know how to what to say to him. They just have to witness that every day. We also have complaints of verbal sexual harassment. Seniors, consultants been saying very bad, very impolite things to female students, and it's been going for quite a while, and it's actually a public secret. We call it public secret. So everyone knows that, but no one can do anything about that, or no one is daring to do anything about that. But he's a very senior consultant, and also classification. There is one senior consultant who is well known for receiving. Not really. I don't know if he's asking.
It's not.
But students have this tradition of giving him, a bunch of presents, food or something, before during their, the middle of their status. Brown, yeah. So, and it's really considered important because they say the students perceive that it will affect their examination score. But when we challenge them, we ask them, have you really asked him or her that what if you don't do this? They have no idea because they got it from their seniors and it goes down and it's like this warisan, yeah. Yeah, and we try to, why not try not to do it? Let's see how it goes. And if you don't pass the exam, and they have evidence of what they do in the department. So it's easy to trace that and see why are students not failing in that department, and so we can start to investigate it. But if you don't do anything, no one will investigate that. It's really difficult. So these are problems that we know. But for us, it's also difficult what we should do, because now that we know, we should do something about it. Without being a whistleblower or something, yeah. It's quite difficult it's a burden for us to hear all these things and not being able to do something, or not for now. But we promise that there should be something done, and we should start to do something about this. Yeah. So for the ethical case discussion in the clinic, in the clinical phase, we use just 4 of these steps because the other steps they have learned to identify ethical problems, and they turn up with really interesting ethical problems. So this is what we use in our discussion. Yeah. Oh. Thank you. I think that's.
Thank you for sharing with us what your experience in Indonesia, your thought in Indonesia. Questions and comments? It's not that we still have some time until 11 actually, about 15 minutes before we go to
20 until 2014. We had bioethics. It's not standing alone. It's integrated in the health law. So the name of the block is bioethics and health law. Since, like Amalia said before, that the students tend to love like law, something that's written. So when they discuss the cases, they always refer to the regulation of something. So yeah, I think that we were very lucky, but at the first, we also have to deal with some kind of problem. So,
just to ask, after this 2014, start separate the bioethics from other curriculums. So comparing between integrated systems, so embedded into the other posting, which you can discuss case scenario, actual case, and then later on embedded bioethics inside that, or compare with your curriculum, the separate, isolated course. So, what's your comment between two places?
Yeah, the previous curriculum was actually not that different because we had six blocks of bioethics and health law. So it was called BHL1, BHL2, until 6. But each of them were for 1 week, combined with medical legal, so health law, code of ethics, all these law or yeah. And even during that time, the PBLs, the discussions were only about ethical problems. So we, like in USM's case, we have the clinical discussion, yeah, right, the clinical case discussion. And then you have one question of ethics.
We have an ethics component in every case.
Component in every case. We tried that in 2004, doing that, I think for 2 years, and it was very ugly because the ethics component is not working because the ethics component was often left out. They didn't have enough time to discuss it. So it was because they would run to the, like Woro said, the regulation and easily say, no, abortion is not allowed, period. And then because they don't have any time to deliberate their opinions. So we stick to the case problem, the ethical case problem. So there's one scenario, there's one ethical problem, and it's really mainly about ethical discussion, deliberation, and finding best alternative solutions for that case. But in terms of integrating, students also thought that it was somehow fading away after each block because it was too short. We only have 5 days of ethics, and we only had 1 or 2 group discussions, which was not very. They did not remember it at the end, and they thought, why not have a longer block? That was where our evaluation with the students, and so that's what we proposed to the education unit and argued, can we have longer block and then like replacing everything, moving this and that, and we came up with these 2 blocks. Did I answer your question?
Yeah. Terus USM doing initially integrated, then later on because of MQA, then you develop separate block.
Yeah. What one would be most?
No, we from the very beginning we have the separate block, but the enhancement of the application is integrated.
Because I try to understand what's the reason for us to split into the isolated block or the ethic rather than embedded. Because nowadays people are talking about integrated system, so you should teach integrated between the clinical, preclinical, and then between the subjects. So now we're talking about the opposite direction, of the ethic being isolated from other component of teaching. So I'm asking what triggers you to change. You say it's not working lah.
It is not really separating. It is that when you want to put the theory, you put in a specific block. The reason why we put in a specific block for giving out the theory and the introduction of the whole concept is because we think of the accreditation of a medical degree program, that means our graduates, to other people, not just in Malaysia but also international, because we have to move forward to prepare our graduates not only working in Malaysia but also elsewhere. So when we look into international accreditation or international recognition of medical professional training, they want to know whether you really put the effort to teach professionalism and ethics. So you need to be appear in one of the course in their transcript. But on the enhancement and the application of ethics, it is embedded, it is integrated. But you need a proper documentation of how you embedded that one, integrated that one, and so on. So that is what we work out. So it's not really separating. It is just making sure that the theory is put up, but the application, of course, because it is something that practical, we don't think that it can be just in a lecture hall.
Somehow I tend to set some time aside for ethical teaching is a good thing. It's like if I compare to anatomy. Of course you learn anatomy first and then you go and apply it. So I think maybe like this, I think it's good to set maybe some time apart for aside or some dedicated time to talk and to really talk about ethics for the students as well.
Yeah, you mentioned about personal behavior. We are a bit different maybe from other when it comes to Indonesia. They don't really point out this professionalism even in our block because it will come up. It will come up eventually, and we don't think students are mature. Yeah, we don't want to lecture them with how to be professional. We know that. That's why the code of ethics is introduced at the end of this block. We want them to open up their mind, and we say no, all legal and regulations thing come at the end, because so during the first and second year, they are free to say or to think according to their own values and what they have learned So that's why we think it's important to do that, and also what you were thinking about, why when ethics is integrated into other blocks, it fades away. Like you have
Yes.
1 week, during 1 week we have 1 hour of ethics, and then next week one, and also like we put one component in the in our place, it doesn't seem to it's apa tuh nempel.
Attach.
Huh?
Attach.
Yeah, it doesn't seem to attach to students. So they also said themselves that we can remember anything from ethics. So
3 weeks, 9 weeks total. Now, to me as a beginner, I'm not sure what's the content inside there. Because 3 weeks is 1 week is 3 credit hour. It's a lot, actually.
yeah,
I'm
sorry.
not sure whether we can convince our dean to accept this or not. So how you
Oh yeah.
you need to learn from you how you convince the
Yeah.
some whether
This is-
question is now.
Yeah, this is according to our needs assessment. So it might be different in other places. Even in Indonesia, it might be different in Jakarta, in Yogyakarta, in big cities. This is according to our needs assessment in our university.
But what's the content? I mean, 3 weeks is equal to our short posting like ENT or ophthalmology is 2 weeks a year for. That's all for the.
Yeah. So this block is not bioethics. It's forensics and health law. We only have 2 days of orientation. So it's actually these are the only 2 blocks we have. So this is forensics and health law. We just put 1 or 2 days for that for preparing students for the clerkship. So here we have we introduce the values from the UNESCO core curriculum of bioethics, but we have all these methods which needs time. So we have group discussions, lectures. We have about 10 group discussions for every 2 hours each, and we have the community service for 4 days. So that's already 4 days. Yeah, so we think students are not really that busy at that time, so they like this block. It's quite relaxing, but also it's not that they're doing nothing. They're quite busy, but we want to show you our schedule maybe, but yeah, I can send it to you. But in this block, this is more of what maybe contemporary bioethical textbooks are now about. So we introduce them to ethical issues in reproductive health, in psychiatry, in pediatrics, in public health. They at least they know what potential ethical problems might occur, even if now it's not there yet. So this is also we have quite a lot of lecture and discussion there, group discussions. Yeah.
I think the problem to integrate it is that this is a relatively new teaching that goes into the medical curriculum.
Yeah.
So many of the consultants have not been trained formally in ethics, and
Exactly.
to ask them to teach ethics when they themselves have not been formally trained in ethics is very difficult, and that's why the integrated part may be not working very well. So
Yes.
maybe in the future we may maybe reduce the separate part and become more integrated if all our future consultants have had their own training and they're fully aware of all these ethical problems. But I think this identification of unethical behavior by the seniors is like a common problem, isn't it? I think yes, they got this question as well. So how do we deal with this unethical behavior by the seniors?
Yeah.
It is difficult, isn't it?
Yeah. Yes. It is.
So looks like this is an ongoing problem.
Yeah, it took us now 10 years to have a group of clinicians who are willing to do this, because at first we came there in person, discussing what we want to do. Are they willing to do this? Learning objectives, what we want them to do exactly, and it wasn't easy. We somehow some changed to another clinician, but some always stick there. But now we're quite happy to have a small group of clinicians. That's why we're not yet starting in the clinical in the hospital yet, or just in the undergraduate.
Now that comes to my question. When you talk about the hotline, the individual counselling and so on, it was run just from your ethics member, or is it also involve other clinicians?
No, only the three of us.
Okay. So, do you plan to open up to the clinicians later? Do you think that they will have a good response for clinicians to join in that? Because it's very good if you can get that. But do you have that plan? Or
For now, we have so the dean knows about this. So we have this hotline and everything. But even they are not sure yet how to communicate about this problem. But we think it's much better to have a informal, personal dialogue, discussion with the clinicians that we are now working with in each department. For instance, pediatrics, we have one or two clinicians who are very supportive, and I think, for instance, the case in pediatrics, they would really want to do something about that. But the problem is how we should do it.
yeah.
But I think we are quite optimistic that we can do it. We can open up to them informally and personally, interpersonal. I think it has to be done.
The center or is it a separate department or a center which runs this or implements this curriculum for bioethics?
Department.
So it's a separate department.
Yeah, it's
not within medical education or separate department.
yeah. We only have 5 people there actually, so it's a small department, but it's yeah.
While I'm with USM, I experienced as a tutor in USM. I also was involved once or twice with the new curriculum. What is, I think, critical is when we go to each case and then we have to establish the questions for the bioethics part. Sometimes it's not something, it has to be not something which is too legal, something which is too leading to legal discussions from legal perspectives. But for example, more or less probably about empathy, about how you think about patients who has been the sole bread earner, the one who is the source of income for the family, have to leave the job for months to stay on the wards. So that's not being empathy like that is one. But then, but yes, during discussion itself, we are lucky we have mercy, because then we have the guide not to get lost into something too legal, something which is too sound of legal. But most of the time, the students they ask about, are we allowed to do that? So this is going to be something more legal, and then you have to put them back on track. But yes, we because we have mercy, then it's more guided. So that's having guides. I think one advice that we can do, and then yeah, it's a challenge.
Yeah, we were also wondering yesterday what in USM, because you have this integrated PBL, if you have enough time to discuss the ethical problem there. Because in our place we have an ethical dilemma, which is we think for a dilemma to be discussed needs at least 1 hour in a group. So we were and we also use the 7-jump method, from Maastricht, for PBL in clinical cases. So it's not possible to combine that. It's difficult to combine that, and we need at least 1 hour to discuss the ethical dilemma there. So we think I think we should separate this from the clinical case discussion.
Okay, thank you very much. We